Today I'm very happy to see the residents around it every morning, and I just want to reinforce a little bit the issue of active drainage, which is kind of essential, especially when you drain a complex collection. And so, you know, I know you all know Greek. This is kathietai, which is to send down, which is the origin of the word catheter. You know, and this is one of the catheters that David Ballard, the former medical student of ours, sent in from Malingrod on a patient that you can see the catheter is filled with residual pus and debris on a patient that obviously that was not doing well, and was not doing well because they were not irrigating those catheters. This is a patient with Crohn's disease with right sophrenic and right gutter access that we drained vigorously, and you can see here, and with good karma, and did very well. And this is a patient, recent patient with a 45-year-old female with retroperitoneal abscess that you can see here, the images, you know, that actually I can even point it out with the, what is it, put it on. You know, you have a nice here in the retroperitoneum, and then after a vigorous drainage, she was discharged 5 days post-drainage. And if the videos work, this good karma can be seen here, the abscess before the drainage and after the drainage. Come on, come on, come on, come on. See, so vigorous drainage really pays off. And this is another patient, recent patient that we had with an enormous, they started post-colectomy, abscess with fistula, and this are the catheter we placed, and it was a very rewarding case. The patient now is an outpatient, took a lot of work, and you can see the patient with this air which is outside of the bowel lumen. Look, the stomach all compressed because of this collection and the collection here. There were abscesses, and this is after we drained him initially. And this is the team. We drained more than a gallon of very, very, I think the most foul-smelling pus I ever had in my life. Patients with necrotizing pancreatitis, you know, have a very interesting and challenging management. This is a patient with, you see, a massive left-sided pleural effusion. Look at the collections. Patient has pseudoaneurysms and a collection that really went to the pelvis. We drained it with nice-sized catheters, and after the drainage, we did video endoscopy, and you can see here using the sizes of the catheters to, this is the catheter size after, to insert a laparoscope, look into it, and do removal of the study. The patient was like this. This is practically like an ECMO machine, and this is the patient recovered and went well to Monroe, back to Monroe. This is another case that came also from Monroe with necrotizing alcoholic pancreatitis. Look at the size of these collections. This is the patient. This is the drainage. And this the initial drainage with 6 catheters. We did daily irrigation, and this is what you obtain in the irrigations, and this is the patient on follow-up. And actually the patient is still alive. He called me every year for my birthday and for the holidays. Don't forget also the trans-orificial route, in this case a trans-rectal route, a 64-year-old woman with pelvic access for radical hysterectomy for Mullerian tumor. This is the needle in the collection seen transrectally. This is the wire, and you can see here the catheters. This tape is a 20 French catheter because it was very thick, the pus. And also, when you have associated upper and lower pelvis abscesses, you can drain both of them. This is a 13-year-old girl. The abscess is here in front of the bladder, and the abscess posteriorly there. You can see the abscesses here. And those abscesses drain successfully like this, and the patient did well. Sometimes we have challenging patients. This patient is an obese patient with a motorcycle accident, had rupture of the spleen, embolization, and developed an abscess of that area of necrosis, from the spleen. And you can see the abscesses here. And our drainage, we thought it was good karma, but it had a bad karma, because after we put 2 nice big drainages and everything looks good, this is at the end of the procedure, 24 hours later, look at this. The whole left hemithorax, that's to tell you how sometimes when you were looking at everything that was in the abdomen, we went through the pleura, and this is what happened. And so we put a big chest tube, and the bad karma turned into a good karma because the patient left without any problems after the chest tube drainage. Was a little chubby, as you can see. Another thing that had bad karma is when you put a small catheter and the catheter is floating in there and nothing drains. You can see the catheter here, the catheter is located here. This is floating in the collection. It's a lot of residual. The patient will refer from the private practice to us. So what we did here, when he came from this, we went to this. We put 2 20 French catheters. And with this vigorous drainage, that collection on the right, hemiabdomen resolved. So today we're going to talk a little bit on image-guided drainage karma, So I have nothing to disclose. Remember, karma is, in Sanskrit, means action. And in order to understand karma really well, you need to get a guru. A guru is a master or mentor, that will introduce you to the deep knowledge. So I started my search, and they sent me to the Himalayas. In the western part, it's Pakistan. Here is Kashmir, and in the other, in the eastern part is Bhutan. But Nepal is where the things are, This is the Mount Everest there. And I went and found in Kathmandu my guru, And so, you see, this is key. This is okay, So he first introduced me to took me to a world of understanding and everything, and I tried to see what was going on. So he told me that catheter comes from the Greek, catheter katinai, as I showed you initially, to send down, and drainage is an Anglo-Saxon word that comes from drain, to draw off. So when do we put a catheter? We put a catheter where there is a safe pathway from the insertion site, could be the skin or transurficial, to the collection. We try to treat symptomatic sterile collections when they cause mass effect, pain, or discomfort, or infected collections more than 3 centimeters in diameter, because that diameter is the size of the pigtail. And so if you want to have a catheter at this stage, you need to put a pigtail. And there is no pathway for or a small site for catheter insertion. Consider needle aspiration, that we have done many times. So image-guided catheter drainage is active drainage, okay? The catheter drainage is an active process. When you insert a catheter, it ties you to the patient until the catheter needs to come out, and even sometimes in the follow-up, I will show you some of the cases. And that's like good karma. Passive drainage, which means to put a catheter and leave it to drain by itself without responsible attention, not following the clinical evolution of the patient, or letting other services take care of the catheter and removing it, is really bad karma. And that has been the cause why many of our procedures shifted from interventional radiology to other specialties. So the principle for immediate catheter drainage, I have repeated them, and which is know who you are draining, know the patient you're going to be draining, know what you are draining. If you're seeing a simple collection or a complex collection. Simple collections are those that have a clear liquid or a post-operative collection without fistula. Complex collections are fistulas with abscess with fistulas, infected hematomas, particulate matter. Drain the collection well. Do vigorous drainage when you need it, and follow up the patient and the catheter. The catheter size karma is you use small size catheters when the fluid that you're going to drain is low viscosity, like happens is in ascites, urine, or clear fluid cysts. You know, some of the cysts have necrotic debris, especially if you're going to, not so much cysts, but pseudocysts, like in the pancreas in the bottom, they have necrotic debris. So larger size, 12 to 24 French or larger sometimes, for large volume, high viscosity, fluid, and fluid with particles. A 6 French catheter may be used in pediatric patients. This is a case that I wish we had the video. It's a very large hematoma in the, from a patient with the post-splenectomy. And this is pieces of debris that we've taken out for patients that with a small catheter, you see they cannot come out. Come on. So catheter number karma. You know, it's multiple catheters are necessary for drainage of multiple collections. If you have 2 or 3 collections distributed in the abdomen, you need to put more than one catheter. Obviously, you need to evacuate them. Pair catheters are used for large volume, more than 6 centimeter complex collections, and pair catheters is the insertion of more than one catheter within the same collection to facilitate vigorous irrigation and drainage. The catheter insertion location karma talks about the use of safe, shortest pathway to the collection and use subcostal instead of intercostal access for sophrenic collection when possible, and fundamentally think on the patient in bed so when the patient lays down will not lie on the catheter. Because sometimes we have seen, and it has happened, that you put a catheter and it's here in the back. That you are destined the patient not to lay flat. Active drainage karma, daily follow-up for inpatients, check catheter fixation to the skin, check daily output and fluid characteristic, check for residual and drain fluid, aspirate before you inject or do anything, effective irrigation until the irrigant returns clear, and stop irrigation if not recovering irrigant volume injected. If you take 60 cc's and you get 20 or 30, stop. That fluid is somewhere inside of that patient. And keep the catheter patent. At the end of your procedure, the irrigation, flush it with 5 milliliters of saline or Dakin, whatever solution you're using. When do we take the catheters out? We have the click criteria. The click criteria is clinical, when the patient has general improvement, it has no pain, the fever is down, and so forth. Laboratory, normalization of a normal test in the case of an infection, decrease of the white cell count. Imaging, when there's no residual cavity or fistula. And catheter, when the drainage output is less than 10 milliliters a day. And this is, click is a mnemonic for you to say, when you ask an attending, when I remove the catheter, you need to think, is the click done? Remember, of all this, imaging is not absolutely necessary. If the other 3 are working, the imaging is not necessary. For instance, a periappendiceal abscess. The patient is doing well, it has no fever and everything, laboratory white cell count is normal, the catheter is not draining anything, you don't need to do anything in that case. So we have developed some advanced techniques. One of these is a pair drainage catheter that you all residents, you see it all the time, but this is not commonplace. Now it's more generalized because we have done it now for more than a decade. We started in the 90s doing this. It's an enhanced catheter drainage technique consisting of inserting more than one drainage catheter through the same skin hole or separate skin holes within the same collection. It's used for large site collection, more than 6 centimeters in diameter. Complex collection with fluid with particles. Facilitate collection cavity irrigation to remove and completely evacuate its content. This is one of the old cases in the sense that we did use the same tract and we use access needle, we have passed there, we put a vascular sheath, we have one wire, we put a second wire, we put, this case is a 20 French catheter and a 10 French catheter. This is the Gordon catheter, and this is a Boston Scientific pigtail catheter. So these are very old, but you see this, they used to do it for a long time. And this is what it looks like, on when we are both put into place. You can put them again a single hole. Here you have 220 talc wicks together, and here there are two skin holes separately. This is better in the sense that sometimes there is leakage around the catheter in between when you put it through the same hole. Peri-drainage catheters, you know, is another one, draining a hematoma. Hematomas, you really need to have two catheters to irrigate and get the clots from there. And this is what you do with the irrigation that we use, Dakin solution, you know, that really helps for several reasons. Helps remove the necrotic debris, and also, very importantly, is also deodorant, because some of these patients really smell. So perforated bowel abscesses are also some kind of challenging abscesses. The contents pass with the enteric flora. It has a communication with the intestinal lumen. The cause usually, the most common is postoperative or can be spontaneous, like appendicitis, diverticulitis, Crohn's disease, or cancer. Think about cancer, even in younger people. This year we trained a patient 40 years old with a perforated left colon cancer. And they manage drainage with multiple catheters, 24 French, antibiotic, nutrition, and sometimes surgery, because the definitive cure, for instance, in the case of a patient with Crohn's or appendicitis, diverticulitis, is going to be surgery. So these abscess cavities and fistulas will close when clean and dry. That's a basic surgical principle. If you keep them empty and you keep them and clean, they will close. So the good karma for perforated bowel abscess is an effective, complete evacuation of the abscess cavity that may be enough to resolve the abscess by itself with a fistula. You know, many times they close by itself. You know, like happened to one of the guys I showed you at the beginning. A persistent fistula with resolving abscess cavity benefits from cannulating the fistula. You know, you put a catheter within the hole in the bowel. And the catheters are downsized until the cavity resolves and is followed by fistula closure. And that is a pretty good method or systematic to face these cases. And that technique, we have published it in 2015, you know, in collaboration with our team. You know, here you see the perforated bowel abscess, you know, two catheters. When it decreases in size, we cannulated the fistula and we drain the residual cavity. The residual cavity is closing, and finally, when it's practically nothing is clean, we take the catheter out, and that's it. So the conclusion is, from image-guided drainage karma, is an active process. It's effective collection evacuation. That's number one. You need to empty the collection. When you come in the morning, check the drainage catheter, and you get 50 cc's of residual pus or whatever, you know that catheter is not well placed or needs something else. Consistent follow-up with irrigation, assertive continuous clinical and imaging evaluation to include additional drainage maneuvers. You know, as you have seen, with endoscopy sometimes is necessary, or sometimes removing foreign bodies, like drop stones in a patient that had a cholecystectomy and the gallbladder was broken and the stones spilled in the abdominal cavity. If you have a clear criteria for drainage catheter removal, and if bad karma occurs, surgery always remains an option. You know? In any case, in image-guided drainage karma, my guru and mentor was Dr. Eric van Sonnenberg. He is one of the fathers on non-vascular interventional radiology. Here's a picture of him. This is Giovanna Casola, who's a CT specialist. He also did interventional radiology. And me doing a percutaneous cholecystostomy many moons ago, in 1988, you know, in the ICU. You know, it was different at the time, but it still works. And well, in search of my other guru, this is in Kathmandu, in Nepal, a Buddhist temple. And this is a Buddhist temple in Cambodia. And this is Angkor Wat, which initially was a Hindu temple. It's enormous, miles, you know. And then ended being a Buddhist. Cambodia is a Buddhist country by itself. And these are some friends I made there, you know, in Kathmandu. And my guru, when he was talking to me, telling me all these secrets. Thank you so much. Any questions?
talking about? I know the point is to keep everything dry, and then you're given the tissue cannulation of a fistula.
Yes.
So I know you're wanting to keep everything dry, and then that kind of, the cannulation spurs the tissue to heal itself back up? Like what, I don't know.
The cannulation, the issue the cannulation does is try to channel, whatever to the hole in the skin.
Okay.
Instead of spreading, and this is all, I don't have a translational or a laboratory mechanism, but it would be nice to try to do that. My belief is that when you put it has worked for us, and the fact that it's published is also have been reviewed by people that JVIR is a kind of a nice journal.
Right.
And what it happened, it really didacts the flow, because the rest, what it seeps around, it gets cleaned up by the other catheter, the draining catheters, okay? Mm-hmm. And many times when you have a high output fistula, I didn't go into detail of each of these things because, each of this, what we have talked, you can talk like 10, 15 minutes on each of these things. Mm-hmm. But you can add, when you have a fistula that is more than 200, 300 cc a day, you need to be thinking, should I, in order to keep it dry, should I add continuous suction or intermittent suction? Okay, you see that usually we do not do suction to the wall. And we don't do it because it works. You can add many things like irrigation or suction, but you need to be very selective when you do those things. Because when you do those things, sometimes, especially irrigation, continuous irrigation, you lose a lot and you complicate a lot of things. And sometimes, not now because the technology has improved, but in the past, continuous irrigation, when to maintain the flow and everything, it was a mess in the bed and everything. But as a bottom line, what I think is that putting a catheter directs, the flow and blocks somewhat the hole, while the other catheters that are around, okay, you don't want to aspirate the fistula. You don't want to aspirate the feces or something like that. What you want is whatever is coming out, that juice with bile and enzymes and everything is going to be aspirated by the other drainage catheters. Maybe if you put even a rod, it would work the same.
So what do you think is the point where you pull the catheter to get it to completely fill in? Or what's the turning point where you're keeping everything dry, but then you close the hole?
Okay, yeah, that is very. Usually you do that after you remove the last catheter to pull out is the fistula, because it means everything has been closed around. Remember, when you have an abscess specifically, because this act like an abscess because they are fluid collections that have biologically active juices. So there is a reaction of the body, if the body is enough to make it, creating inflammatory tissue that walls off whatever the collection is. That inflammatory tissue, if you keep it clean and you let it stick, because it's empty, that thing closes in hours. Okay, hours, not days, in hours. However, sometimes it's very hard to achieve a clean cavity. That's why the irrigation comes across, and that's why the irrigation with Dakin comes across, because Dakin is a solution a good solution of bleach. Actually, because Mr. B, Mr. Bates, the one we did, you were going to ask $100 for a liter of Dakin solution. And actually, if you got 50 milliliters of bleach in a gallon of water, and that costs you $2, So, but I'm saying you use that because also it's a disinfectant thing, and we have used it for decades. I used it when I was doing oncologic surgery. We had fistulas, with everything. So it is safe. We have presented it at the SIR many years ago. As a poster. I presented a lot of things as a poster and never published anything about it. Some of them come out because, I'm too impatient. Any other question? I think, the success of drainage, you need to work with the catheters. You put a catheter, you can ask David Ballard to send me that picture. You know, you put a big catheter, but if you don't work with the catheter, it's useless. You know.
They don't do daily rounds or anything?
Well, I don't think they round daily, and they leave a lot to do to the nurses. And it's not bad to leave it to the nurses because in San Diego, for instance, once every 3 months or 6 months, I had a double interest about that. You know, these nurses, most of them were Filipino nurses, you know. And so we got together Saturday morning, and I told them how to clean and treat the cat. You know, and they brought me with food, Filipino food. But it was great because sometimes, especially in pancreatitis, and we were a very referral center for pancreatitis, you really, at this patient, you need to do it more than once a day, like we have done with Bates, and we have done with I think it was Tulo was another one.
The fish.
Yeah.
The fish.
You know, but those people need extra work. So, okay. Anything else?
Any contraindications
For what?
for drainage?
Contraindication for drainage, well, I mean, I think the contraindication, we talk a little bit here, is if whatever collection you want to drain is less than 6 centimeters, you know, you probably diagnostic aspiration if it's a safe pathway, and if you cannot reach it, you can use antibiotics. Remember, antibiotics is one way of treating appendicitis, one way of treating cholecystitis. Now, the course of what's going to happen afterwards, you cannot predict. You know, if the appendicitis is very acute, you may be able to resolve it, like happened with the cholecystitis. But the chances are that you're going to give antibiotics and the things are going to get worse. For instance, in the case of an appendicitis, it can perforate and become, usually if it smolders, you localize abscess. But if it's kind of abrupt and everything is peritonitis, and that happens usually in children. That's why you see many of the appendicitis in children, they're not operated when they are acute. You know, later on, you know, like also in elderly people or pregnant people, or when they decide to operate, it's already late and it's already the infection has spread about the abdominal cavity. You know, and the other in cholecystitis, instead of having acute cholecystitis, you have a subacute cholecystitis. And subacute cholecystitis is bad for the surgeon to operate, and it's bad for us to drain. Yeah, exactly.
Horacio, are in that situation, it's better just to drain and wait until everything goes better and then they operate? I say for perforated cholecystitis or appendicitis.
Yeah, well, in reality, and we have done that study, well, we do it again. What happened with the cholecystostomy patients? You know, many of the cholecystostomy patients, well, I think when they ask it initially, patient with risk or so forth, the best thing is cholecystectomy. But if the patient has risk or has had 2 or 3 days, you know, everything is matted down there, we do a drainage, everything cools off, and then they do a cholecystectomy.
I think that's the criteria that they are using, the surgeons, just to cool down a little bit and then operate the patient, not operate in an acute setting.
You're right. What happened is the patient with acute cholecystitis, instead of coming immediately to the doctor, spend 2 or 3 days and they take something, pain medication or whatever. And then 2 or 3 days later, you know, everything is subacute. And subacute, you know what? The pedicle of the gallbladder is only debatose, you know, and thickened. And that is when you try to dissect the cystic artery, you can get, you know, another bile duct, and it's not uncommon, you know, those things, or injure the artery, you know. So that's why cholecystostomy has a role there. But many of our patients that we do cholecystostomy, when especially in the ICU and everything, they never get to the cholecystectomy. You know, they die from their other comorbidities, or they end. We have removed stones. You know, we do cholecystectomy. You know, patients with calculus cholecystitis, and some of them, the catheter has been pulled out and they chug along. You know, sometimes they come back, like happened with the patient we did together. She's I don't know what we need to follow her.
I am doing that. She's
You know, we need to see where she's at because I don't know what happened with that. We
She
can
went
remove
home.
those stones. It's easy. Taking the stones is not a big deal. We don't do it ourselves alone. We call the urologist. You know, they look inside, or with the last case we did it with Dr. Griffin. We did it with Johan, you know, with the cholesterol. You know, you have to see the little fragments, take them out.
Going through the external catheter?
Yeah. That's why you need to do, and it's a good point. In order to do all transcholecystic lithotomy, you need to go through the fundus of the gallbladder, because otherwise you're going through the liver. That's why in acute cholecystitis, it's pretty much safe, and the literature supports that. You know, you go directly into the fundus of the gallbladder. Makes the procedure very simple. You know, how long will it take you? Like less than 5 minutes. You know, it's Seldinger because you have a good target. Amplets, you load your 10 French with the middle. You do, and that's it. Any question? Thank you so much. So, you have time to digest.